speakers when they finish it. I call now Dr. Ruli. Ruli is going to tell us and how we can prevent this recurrent disc during and after the surgery. Dr. Ruli.
Yeah, thank you, Jutty. Good evening, everybody. This time I would like to present the topics that given to me. It's about intraoperative and postoperative measures to prevent recurrence. Introduction. Some part already talked by the previous speaker. I'm sorry, but it's just repetition. But it's okay. Negative. See?
Yes.
Oh, okay, I'm sorry. I'm sorry, Professor. Sorry, friends. Yeah, my topic is about intraoperative and postoperative measures to prevent recurrence. And we know that lumbar spine pathology give a negative effect of the physical and physiological, and it's completely disturb our well-being, and it's also disturb economic impact. Non-operative treatment is considered first line and is always the first, and at some point beneficial and cost effective for surgery. It's depend on the indication, and also we have to think that surgery might shortening the pain of the patient, and it will decrease the use of medicine. And revision operative intervention is needed sometimes if the patient become a recurrence. Yeah. As our population ages a number, and the revision lumbar operation is always also become rise, and in terms of fundamental understandings how to comprehensive clinically evaluate patient, and surgical strategies is needed. And this is the cycle of the pain of the patient of the lumbar this herniation and the recurrence. Some patient feels back pain, and they will be worried about the cause of the pain, and then they avoid some movement and activities, and thus it's become disuse of the muscle and depression, social withdrawal, and it even give more pain, and it will circle like this. So our job is to cut this circle. And what we have here is degenerative spine disease is very complex. It's the basic of spine surgical skill, but it's the most complicated because everything is changes inside the spine of the degenerative patient. We can see there's a posterior joint degeneration and disc degeneration, and it will become tearing at the disc, radial tear, herniation, dynamic stenosis, internal disruption, disc narrowing, subluxation, and then osteophyte formation. And somehow there will be like a pseudo pathology of stabilization. Then facet and lamina will be very enlarged and very thick, and thickening of the flavum ligament also, and the enlargement of the vertebral body will make diffuse central stenosis. Thus, the patient will feel not only pain but become paralytic, and it's become multi-level spondylosis. And then the recurrence is discectomy is not uncommon, and it's about like Dr. Sandip said before, it's quite frequent. And one study that about 5 to 10% of patients undergo discectomy and in 1 year of the surgery. Another study report about 22.5 after 2 years, and some report about 30% even in certain patient and population. The disc annulus fissure is the contribute for the reherniation, but the problem is when we do the surgery in lumbar disc disease, we are taking the disc, but we are not suturing all the tearing of the cups, the disc itself. I mean, we cannot find the fissure within the annulus, so because we cannot soon it surgically, it will more likely to herniate again. So it's the concept of the recurrence. Recurrence of this within 6 months is defined as with recurrence of this herniation in 6 months after successful free interval, free pain. I'm sorry, free pain and at least 2 weeks, and then complete removal proven by follow-up MRI after 6 months. It's associated with several factors like Dr. Sandip already mentioned, and play important role in the failure of degenerative disease, occur in 60% cases somehow. And what we have here that we have to know exactly is that the recurrent or the fibrosis after surgery in the same position. So we need to do SLR test, and we can find co-reproduced pain, and it will lead us into reherniation, recurrence, I'm sorry. Recurrence can occur at the same level, same site, opposite, or entirely at a different level. And how to measure it after surgery? This is some question I try to find. And first question is, how many spine operation have you had previously? Because sometimes we can receive patient with more than one surgery before for the herniation. And who perform is important because we can talk with the surgeon, and we can avoid to repeat what they did to make a different approach. And why was the original first spine operation the indication, I mean, and what was the indication to do the surgery? How about the symptom itself at the first time? Why the patient have the surgery? If there are any complication during after surgery, and is there any new neurologic symptoms after surgery? And the current symptoms is very important. Is the same symptom, or it's different, or it's more severe, or it's become better? Because if it's become better, maybe we have to think it's not the herniation, but maybe it's a fibrosis, a cicatric, or something that we can do conservatively before. And patient must ask about the concern of their posture. They can feel that their posture become different after surgery, like asymmetrical sitting position posture, and how about their walking tolerance, and what is the non-operative treatment have been given after the first surgery, and when it's diagnosed as recurrent, and what non-operative treatment have been given, and the goals of surgery of the patient. It's very important, because sometimes as a surgeon we like to say that the best treatment is this gitu, but sometimes the best treatment for the surgeon is not the best for the patient. So we need to ask after the first surgery, and what is your goal if you want to do the second surgery, and what is disturb you the most compared to the previous one, and what do you want most now? If they just want the pain be eliminated, and you cannot find the recurrence, and you cannot find the proof, maybe you can do another alternative, like Andrea said about the pain management or injection. This is the radiology evaluation. It's sometimes, not sometimes, I mean, the big picture is we can define the first surgery as with prior fusion or no instrumentation plus instrumentation, because it will make us to take another surgical opinion. If the patient already do the fusion with the disectomy at the first time, and just disectomy at the first time, we can find another approach, and find the better solution for the patient. And then most of all, we can divide there are 4 problems coming with the patient with recurrent of this herniation. We have to keep in our mind that we do no harm to the patient. So if we cannot make it better, don't do anything. So you have to find the solution, and we have to think carefully and rethink again about the option. First is about the revision decompression. If we can find the cause is about the reherniation only of the disc at the same level, because the fissure is it's reprolapse and it's coming again in the same level, then we can redo dissectomy. Some surgeon might use the second surgery, redo dissectomy with endoscopy, but I have a bad experience actually, so I would not suggest for the second surgery using MISS. In my opinion, the second surgery, it should be open wider than the first one, because the tissue already psychiatric, fibrotic, adhesion, and so on, and we need to open wider for the second surgery. And if the problem come to the second adjacent segment disease, it means there's more than one level involved in the disc of the patient. So if the first surgery is not doing the fusion, so the second surgery must include the fusion and extension of the fusion itself. We must include the adjacent segment. And actually, I mean, it's also with dissectomy, of course. And if the third problem is about pseudoarthrosis, if patient come with pseudoarthrosis, it means we need to find different approach, and we need to make a circumferential fusion and make a better same strength, same power. I mean, same I don't know what to say it. Same strength between 3 column. I mean, so we need to put it in a fixed line in the spine. And if it's come with reherniation and all more alignment and listhetic, and so we need more osteotomy and rigid fusion after that. And but it's depend on the problem of the patient. And preoperative measure is early surgery provide relief of symptom twice as fast as compared to the patient treated conservatively. So surgery still the best, but if it's at its indication. Malparesis, somehow it's not an indication for immediate surgery. For progressive and severe paresis, the option might be considered, but amount evidence is restricted. And back pain is not related to the severeness of the nerve root compression, and neither is severe back pain prognostic for a good outcome after treatment. Tubular microdiscectomy is associated with higher recurrence rates compared with conventional microdiscectomy and less treatment satisfaction, but it's relative. It's depend on because the best tool of the surgeon is his hand. So the best surgery is the best skill of the surgeon. So every surgeon has a different preference, and the preference it's about the skill. And pathological instability is the main indication for fusion, so never leave fusion if there's a pathological instability. In patient with spinal stenosis, not only recurrence, severe neurological deficit may appear. So adequate decompression is recommended, and adequate because decompression and stability, it's like more decompression, more instability, more you create instability, and the more you do stability and MISS and or simple opening, the less you do the compression. That it's the art that all spine surgeons should consider. And then intraoperatively, we can do consideration about the compression alone is performed to preservation of the facet joints. It's always leads to better outcome, and as long as you are not needed a wider laminectomy and taken all the structure that become make the stenosis of the canal. Undercutting provides excellent decompression. It's also intraoperative consideration, and it's without aggravating instability in most cases. I personally like undercutting so much, and I like to do it 2 level above, 2 level below undercutting of the thickening lamina. If there is no disc protrusion, no dissectomy is necessary, because we know the first dissectomy will create more fissure and it will lead to another reherniation. So it's become a consideration. If there is no severe instability, infection, extension plane radiograph, fusion can be avoided initially in most patients. And this is our, I'm sorry, I just want to share our PIT, Indonesian Neurospine Society in Bandung, in 2023. This year, if maybe one of you want to join and come to Bandung and see our city. Postoperative measure is Dr. Andreas already said it's about and Dr. Sandip also about using proper lifting technique. Don't bend wet waist, bend your knees while keeping your back straight. It's about exercising, maintaining a healthy weight. Don't put too much pressure on your spine, and make your muscle of the spine stronger to make your spine become better. And do stretching, especially important to take after a long period of sit. Avoiding wearing high heel shoes. Exercising regularly, but I don't know how many times regularly. We have to consult with rehabilitation, and stop smoking, like all previous speakers said. The option, Andreas already said it. It's about the non-surgical choice, treatment, disrepair, healing, injection, and so on. And the second, repeated discectomy surgery. We can choose the technique, but I prefer the second is the better. The second must be better if we open the wider one, and the open discectomy with fusion. And this is World Spine 10 from World Column Spine Society 2024, next year in Bandung. We plan it with the World Column Spine Society friends in December 13 and 15. The conclusion is multiple risk factors, including smoking, diabetes, obesity, intraoperative technique, and biomechanical factors may contribute to development of the recurrent disease. There is widespread variation regarding optimal surgical management for recurrent herniation. Recurrent LDH is a common complication following primary discectomy above the. It's caused because the fissure theory. And the next challenge is determining the appropriate surgical intervention. And then all the important consideration always related to the question that I show you at the beginning of this slide. Thank you so much, all friends and all watching, and Professor Zileli, my teacher. Thank you so much. Thank you, Jutty.
Thank you. Thank you, Dr. Ruli. Very nice to hear. Very nice. What I can say is, though it is elaborative, but you have given every point, what is needed before and after the discectomy.